the top. Hello. So this would be our second Zoom session for 125, hearing disorders. We have Sam Christensen, Renee Ramirez, and Angela Student. Now there's a great last name for a student, Angela Student. Gotta like that. Good first name too. That's my daughter's name, Angela. Gotta like that too. So anyway, I'll share a screen here, and what we'll do is finish our Unit 1 on outer and middle ear disorders. So last week we covered mainly outer ear disorders, and then we got into otitis media as well as being the main middle ear disorder of concern. There's a couple of other ones too. There's Cholesteatoma, which we'll talk about today, and there is Otosclerosis, which we'll talk about today. And then that will finish our Unit 1, outer and middle ear disorders. Where we got last week, we covered all kinds of stuff about cerumen. We looked at all kinds of weird eardrums. And we talked about external otitis and stuff like that. And then we talked about the stages of otitis media, beginning with upper respiratory infection, sore throat, swollen tonsils. That's Chapter 1. Chapter 2, the middle ear space, as big as a sugar cube, keeps absorbing oxygen, and with swollen tonsils, no new air gets up in, because every time you swallow, your eustachian tubes, the end of them opens for a split second, allowing new air in. If your tonsils are swollen, no new air, your eustachian tubes are swollen shut. They will not open when you swallow. And so no new air gets into the middle ear space. You get a vacuum. The eardrums are sucked inward. That's Chapter 2. Chapter 3, the body produces serous fluid. Clear, non-infectious fluid fills the middle ear space in rebellion against that vacuum. Now the eardrums are bulged. Okay? Chapter 4, oh, the four fingers, Ted, big boy. Chapter 4 is that fluid turns white, turns purulent, turns into pus, because now it gets infected, and infected serous fluid becomes white. Now you've got infected otitis media. That's usually where doctors step in, and there's generally 3 treatments. Okay, one is antibiotics. The other one is tubes in the ear, and the third one is tonsillectomy. Tonsillectomy was done for years. In the 50s and 60s, it was normal. I mean, people in my generation always had the tonsils removed to reduce the chances of otitis media. Then in the 70s, tubes became in. Like, hey man, the tonsils are natural, man, leave them alone. And so then you got into tubes more. And antibiotics we've become largely immune to. So basically the pendulum is swinging back now, however, toward tonsillectomy for otitis media. It's a very common pathology. So now I'm going to share screen here, and we will go to take a look at our notes. So I can tell, there you go. And here's where we got to in terms of notes. So if I raise or lower this up here, if I go up here, you can see the treatment for otitis media. And by the way, if you've got untreated cases, pus-filled otitis media can change into mastoiditis. Circle that word, and you'll see clients with mastoidectomies, but those are usually elderly clients, because today we don't let otitis media get to that stage anymore. And of course, in very rare cases, meningitis, because now the untreated mastoiditis has now infected the brain, and the brain is only 1/8 of an inch above the middle ear space. Okay, but this 4 and 5 business here doesn't happen very much today because of today's treatments for otitis media. And when you make sure you look, you know what myringotomy is. Make sure you know how to read the words mastoidectomy. Ecto means out. They've removed the mastoid bone due to mastoiditis. And then you've got a term tympanoplasty. Every time you see the word plasty, that means they did surgery, plastic surgery. Myringotomy is a hole punctured into the eardrum so that they can suction out the pus-filled fluid. But basically, the treatments are threefold. And they're not listed here so much like that, but make sure you've got those. Tonsillectomy, antibiotics, and tubes. Those are the three general treatments for otitis media. Now let's cut to the chase today, or actually where we said we'd pick up today. Audiometry and otitis media. It begins as a low frequency air-bone gap, normal bone conduction thresholds. Okay, hearing by bone conduction, totally normal. If they take off the, I'll stop sharing for a second. If they put a bone oscillator on the mastoid bone and deliver sound through the skull, the hearing is completely normal with otitis media. Okay, there's no hair cell damage. The cochlea is fine. It's only when delivering sound through a headphone that you encounter the mechanical blockage of cerumen, as in the case of outer ear problems, or pus-filled middle ear, as in the case of middle ear problems. That's why they call it a conductive hearing loss, because outer and middle ear disorders mechanically block the passage of sound. They block the conduction of sound. So outer and middle ear pathology result in conductive hearing loss. Normal hearing by bone conduction, abnormal hearing by air conduction. That's the essence of audiometry that way regarding otitis media. So looking here, sometimes an improvement at 2000 hertz in air conduction. Let's see if we've got a picture of that. So let's go to our drawings here and look at, here you go, typical otitis media audiogram. Look carefully at this one, real carefully, okay? Because you can see air conduction for both right and left ears is a moderate, mild to moderate in degree, 45-ish, 50, and then look at that improvement at 2000 hertz. And then back down again. So why the improvement there? Because that's the resonance of the middle ear ossicles. Look at the top bone scores. You can see unmasked bone for the left ear, and you can see masked bone for the right ear. So always remember how your bone conduction scores look, okay? The greater than reflects the left ear, because you think of the client facing you. If the client's facing you, his or her left ear is going to look like this, okay? And the right ear is going to look that way. So this is always left ear bone conduction, and then in this case they flipped a coin and said, well, which ear do you want to test first? Doesn't matter. Put the mastoid oscillator behind, okay, behind the guy's left ear. Do bone conduction testing, normal. Now put noise in the other ear to keep it busy and make sure that we find the same bone conduction thresholds for the right ear. So this is indicating pure normal bone conduction hearing for both ears and a bilateral air conduction conductive hearing loss. Okay, cool. Now let's go back to good old share screen and let's take a picture of, okay, let's get out of here and look at our notes again. Speech audiometry. Okay, now remember the ranges too. Okay, remember the biggest conductive hearing loss you can possibly have depends on the headphone. So what's the biggest otitis media that you usually see? Around 50 to 60 dB, around that. That's an average degree of otitis media, very common, but it begins as a low frequency air-bone gap, right here, where I'm. So you're going to see the conductive hearing loss at early otitis media beginning below 1000 hertz. And above 1000 hertz, air conduction will be pretty normal. But as the otitis media advances, now the hearing loss becomes flat. Bone conduction normal, air conduction here. okay, with a little peak at 2000 hertz. All right. Ranges from about 15 to 40 to about 40 to 60 dB in degree. Speech audiometry by air conduction. Well, SRTs, okay, are going to be elevated, of course. So if we look at this audiogram here, I'm not sure if I've got a picture of that. I doubt it. This isn't an audiometry class, but look at the pure tone average. Okay, pure tone average, 50, 45-ish 50. 35. If you add those up, divide by 3, you get the PTA, Parent Teachers Association, okay? Pure tone average. And what needs to agree with pure tone average? Have you taken Audiometry 140? Have you guys taken that yet? Or I should say 130? Good. Well, then you know SRT has to agree with pure tone average. So if you've added these 3 numbers up by 3, or I should say added them up and divided by 3, you're going to get a number something like around 40-ish. So your SRT should be around 40. And then what should the most comfortable loudness level be? When you think about this, what do you think the person's MCL is going to be with a plugged up ear? And since we're online here, I'll just ask you, what do you think? MCL, well, it's written down there, so you can always cheat and look at the writing, okay? In your notes, it's going to be elevated because the guy has a plug in his ear. And the plug is called otitis media. He's got a plug of pus in both ears. Well, when we wear earplugs, we want to block the sound out from the loud lawnmower, so we put earplugs on. Okay, well, it's the same thing with the conductive hearing loss. Conductive hearing loss is like wearing earplugs. You're blocking the conduction of sound. So the person's MCL is going to be way over here, like around 90. Look where my cursor is, because he's got a big plug in his ear to the tune of about 40 decibels. So his MCL is going to be way up there. His UCL, uncomfortable loudness level, is going to be off the board. You can deliver 120 to the guy's ear and he's going to say, bring it on, buddy. No problem. That's what you'd say if you were wearing earplugs. That's why you wear earplugs. Okay? And now if you're at MCL and you read him words for speech recognition or speech discrimination, and you read him words at around 85, 90 dB HL, that's going to sound most comfortable to him. And when you're saying, say the word cow, say the word tree, say the word up, say the word head, he's going to get all of them. He's going to get every stinking word. How come? Because he's got normal hair cells, normal cochleas, no problem hearing in noise. He just can't hear. He's got a plug in his ear, but you turn up the volume and God's in his heaven and all's well with the world. He's just, so this is the beauty of conductive hearing loss. Conductive hearing loss has everything going for it. A, medicine can fix it. B, if it can't, they're delighted with hearing aids. They love them. No problem. Sensory neural has everything against it because A, you can't fix sensory neural, and B, hearing aids aid, but they don't bring back normal hearing. Okay, because the hair cells themselves of the cochlea are damaged. And so you're going to make soft, unclear hearing into louder, unclear hearing. And louder, unclear is better than soft, unclear, but that's where hearing aids truly can be called hearing aids. They're an aid. They're like a cane for a bad knee. They help, but they don't replace the real McCoy. And that's 95% of your clients are sensory neural hearing loss. Only 5% of your clients come in with conductive hearing loss. And as HISs, you know exactly what to do when someone comes into your office with an air-bone gap. Medical referral, it's a red flag. You got to get the person out of your office. You may not. It's illegal and immoral and unethical to fit with hearing aids. You can't. You have to send to a doctor and see if that air-bone gap can't get closed. And maybe the doctor will say, you know what? The person's got otosclerosis and I don't want to do surgery on him. So let's aid with hearing aids. Good. Okay, then you got medical clearance. You've got a green light from a doctor saying, go ahead. Okay, but conductive hearing loss, it's very important to know the audiometry that goes with a conductive hearing loss. So now let's get out of this particular slide and look at our writing here. Okay, elevated SRTs, consistent with pure tone averages, elevated most comfortable loudness levels, okay, normal word recognition scores at louder levels, elevated UCLs. So you'll see 4 things there. They're the 4 tests of speech: SRT, MCL, speech discrimination, UCL. Okay? And that's why I listed them right there. Typically what you will see with otitis media in terms of speech audiometry. So you've got pure tone covered, speech covered, and now tympanometry. And tympanometry, of course, is going to yield a type C. So let's look in our notes here, or our good old stuff here, to see if we can't find here good old tympanometry. There you go. Pull this guy up. Come on, screen. I know you can do it. There you go. So when you are looking at tympanometry, here you go. We'll take a look-see at that guy. And there's your tympanograms. Normal tympanogram, type A. Now remember how tympanometry works, as you've learned in 130, okay? Tympanometry. You're putting a probe in the ear. Here, I'll stop sharing so you can really focus here. You're putting a probe in the ear, and the probe has 3 holes in it, right? 1 to deliver a sound, 2 to pick up the sound that bounced off. So one's a speaker, one's a mic, and the other one changes air pressure. So you are sending a low frequency tone. Why a low frequency tone? Because the middle ear is a stiffness dominated system. There's not much mass in the middle ear. I mean, the 3 bones are the smallest bones of the body. They'll all fit on a penny. Okay, so the mass of the middle ear doesn't, and so the middle ear is stiff, the eardrum tight. So they put a low frequency tone in because lows don't go through stiffness very easy. Remember from acoustics, highs resonate with stiffness. Lows resonate with mass. Okay, so they put a low frequency tone in on purpose because they want that tone to bounce back. If it goes through, they got nothing to measure. That's why, WHY, that's how come tympanometry uses a low-pitched tone. And they put it in at about 70 decibels. So it's, and they're changing the air pressure from to while they are delivering that tone. And that tone is delivered at 70. And they're trying to find out how much of that tone bounced back as you changed air pressure. When the air pressure was like this, that meant you've had positive air pressure in the ear canal, normal air pressure behind the eardrum. Uneven, okay? That means you've made the stiff system even more stiff. So guess what? All the sound's bouncing back. All 70 bounces back. Then the air pressure changes to normal. The air behind the eardrum is normal. Now it's even Steven. So the stiff system is less stiff. Guess what? When 70 is put in, maybe only about 35 bounces back. Some went through. And then they make the air pressure in the ear canal negative. So now you've got negative in the ear canal, normal behind the eardrum. Once again, uneven. So you've made that stiff system even more stiff again. Guess what? All 70 bounces back. And that's how you read a tympanogram. So when you're looking at a tympanogram, you're looking at type A. When did most sound bounce back? Right here, positive air pressure. That meant you had less compliance. Look at the axis, compliance. That's the opposite of stiffness. So when they had positive air pressure in the ear canal, you had lots of stiffness. Buku stiffness, not much compliance. All the sound bounced back. Then when they made the air pressure 0 in the ear canal, look at this, you had a peak. You had high compliance, less stiffness, less sound bounced back. And then when they made the air pressure negative, you once again had less compliance, more stiffness. All the sound bounced back. And when you're listening to a tympanogram, you're going to hear it like this. That'll literally be what you hear when you're doing a tympanogram. And your eardrum is going. You're positive to regular to negative. Now look at type C, early otitis media. The peak is at negative air pressure. That meant that to have greatest compliance, look at my cursor, least stiffness, I needed to make the air pressure negative in the ear canal because the air pressure behind the drum was negative. So negative equals negative. Okay, always remember when the air pressure is even Steven on both sides of the drum, that's when the middle ear is most efficient. So if the middle ear is most efficient at negative air pressure outside the ear canal, it must mean that the air pressure behind the drum is also negative. Get it? Good. That's the essence of tympanometry. And I hammer on this point because too few audiologists have a handle on how tympanometry works. They'll go, oh, we're trying to see how much the eardrum wiggles. BS. Have you ever pushed against your eardrum with a Q-tip? Hurts like hell. You're not moving the ding-dong eardrum. You are measuring how much sound bounces back off the eardrum as you change air pressure in the ear canal. That's what you're doing with tympanometry. Anyway, we go like this because we're not IHS, we're OTC, and you're learning reasons why. Instead of button pushing, you're learning to be technologists and not technicians. Cool. All right, so let's go back here. Now look at type C turning into a type B. Look at this. Now the person's getting a fluid-filled middle ear space. The negative air pressure is turning into fluid. Now the eardrum, or behind the ear, the space of the middle ear is producing serous fluid, that clear fluid. And now the ear is beginning to bulge. Okay? You're getting a type C is turning into a type B. And now you've got completely pus-filled middle ear, a type B, flat tympanogram. I don't know why they don't call this A to B to C. I don't know why they do that, okay? Blame Jerger. It's not me, okay? These are called Jerger type tympanograms. Jerger, J-E-R-G-E-R, is a man who lives in Texas. He's still living. He's one of the popes of audiology, James Jerger. But he's the one who coined the names for the tympanograms. Good. All right, tympanogram progressions, various stages of otitis media. Type A, normal. Type C, early with negative middle ear pressure. Type B, advanced with fluid. Excellent. Good. All right. So, now we leave otitis media, yeah, and we go to look at other types of Eustachian tube dysfunctions, yeah. So, Eustachian tube dysfunction. It might not function for other reasons besides otitis media. You could have swollen due to infection or allergy or blockage due to swollen adenoids. Look at this word, Valsalva and Toynbee maneuvers. Now, you've all done this. When you blow your nose real hard, you can pop your ears. Now, when you're landing in a plane and you're beginning to feel that squeeze of air pressure, you might want to try that. You can pop your ears a little bit. And I've learned how to pop this ear without doing that one. If I've only got the problem in one ear, I'll do this, but I'll plug the good ear really tightly with my finger so that no matter what I do, I don't know why, but it just seems to only affect this ear. But you got to be careful because you can blow out an eardrum that way. So never, don't do that. Just slowly increase slowly, and you'll hear sort of a and it evens the air pressure. Those are called Valsalva or Toynbee maneuvers, as in your notes, okay? Scrolling on down, sometimes pregnant women or those taking oral contraceptives report feeling pressure on ears. Hormones that change mucosal lining of the uterus may affect mucosal lining of middle ears. Hey, endoderm, ectoderm, mesoderm. Remember the 3 layers of original embryological tissue. Ectoderm forms muscles. Ectoderm forms skin and nerves. Mesoderm forms bones and muscles. And endoderm forms slimy things. All your guts, the inner linings of things, the inner linings of your nose, the inner lining of the middle ear spaces, the inner lining of the uterus, all this stuff. Anyway, look at this word here and circle that. Patulous or patent eustachian tubes, more common than most people think. These are eustachian tubes that are constantly open. Now, what the Sam Hill would make eustachian tubes constantly open? Sudden and dramatic weight loss. You see, you should think about eustachian tube like government offices, closed unless forced open. Okay? They are normally closed. And they open when you yawn, they'll open when you blow your nose, they'll open when you swallow, but normally the eustachian tubes are closed. But some people who've lost a lot of weight, cancer clients who have been on chemotherapy, or women on crash diets trying to get skinny, bulimia, people eating disorders, people not eating enough, you'll lose tissue and your eustachian tubes are constantly open. And it leads to a feeling that, wow, when I'm talking, my voice sounds like I'm in a barrel, because the voice sounds is coming straight up the eustachian tubes and into the middle ears. Okay, so that's one function of, or a symptom of eustachian tube, patulous or patent eustachian tubes. Okay, now let's get into cholesteatoma. Thank goodness this one is not as common. Skin enters the middle ear space. Look at this. Skin enters the middle ear space, often begins with a perforated eardrum, causes rapidly growing benign tumor, which can then become fatal. Otorrhea, often a foul-smelling discharge. Immediate surgery is the treatment of choice. You've got to get rid of the cholesteatoma tissue because the whole condition can repeat. Forms as a sac with onion-like concentric rings. Don't worry about all these weird words. I couldn't care less. I would have to look at my notes to see them myself. But here's where it is. Sometimes the pars flaccida of the eardrum becomes sucked inward due to negative air pressure. And if this skin opens, then skin from the outer eardrum is introduced to the middle ear space. So think of it very simply. Cholesteatoma usually begins at the edge of an eardrum, like your pars flaccida. Okay, it begins like at the edge. And if that skin opens up due to infection, due to negative air pressure, it's sucked in and it punctures. If skin from the outer layer of the eardrum rapidly tries to fill in that hole, then you're getting skin from the outer ear canal coming into the middle ear space. That's cholesteatoma. Oma doesn't mean grandma, okay? Oma means tumor, okay? Cholesteatoma is a tumor. So let's see if I've got a picture of cholesteatoma. I don't think I've got it there, but I do have it in my other one here, the other PowerPoint. And so let's look at a cholesteatoma. There we go. What do we got here? Acute otitis media, acute otitis media, mucoid otitis media, serous otitis media, mucoid, ventilation tube excluding, retraction, here, cholesteatoma. This slide shows the classic white, cheesy appearance of a cholesteatoma, which in this case is largely filling the middle ear cleft, middle ear space, and is seen through a perforated eardrum. The inflammatory process that cholesteatoma causes may lead to bony erosion and complications of hearing loss, mastoiditis, facial palsy, paralysis, labyrinthitis, in other words, infection of the cochlea, meningitis, okay, can kill you. So when a doctor sees a cholesteatoma, this is just a perforation. See if I've got another picture of a cholesteatoma. I'm just looking to see if here. So another congenital. On rare occasions, weird skin cells may become trapped in the middle ear during early development. So this is from a child where it happened naturally. The result is a slowly growing cyst, the only indication of which may be seen here, a white tumor behind the drum. Basically, a cholesteatoma, here's another one, advanced congenital middle ear cholesteatoma. If left untreated, this benign cyst will slowly enlarge, eroding the ossicles and filling the middle ear cavity. This 5-year-old kid presented with facial paralysis. Okay, so really kind of, if you're looking at cholesteatoma, basically, it is going to be not otitis media, but it may be, what do you call it, a result of a perforation of an eardrum, or it may be congenital. But it's not an infection. It's kind of like skin from the outer part of your ear is growing into the middle ear space for whatever reasons. Could be congenital, some deformation at like during gestational development in mommy, or it could be a perforated eardrum that didn't heal right. And now skin, and it usually is a perforation at the edge of the eardrum that didn't heal right. And so skin from the outer part of your canal is rapidly trying to fill it in. And that's a benign tumor. It can kill you. Doctors will schedule you in for day surgery and get that puppy out because it grows fast. Bell's palsy. So cholesteatoma isn't common, okay? Otitis media is common. Bell's palsy, damage to the 7th facial nerve, causes flaccid paralysis of one side of the face, sometimes resolves spontaneously. So this isn't really a middle ear pathology, okay? But we've got 3 nerves involved in hearing. The 8th nerve sends info from the cochlea to the brain. The 7th nerve is involved with the stapedius muscle of the acoustic reflex. The 5th cranial nerve is involved with the tensor tympani muscle of the acoustic reflex. The acoustic reflex has 2 muscles, right? The stapedius muscle and the tensor tympani. Well, the 7th facial nerve innervates the stapedius muscle. The 5th cranial nerve innervates the tensor tympani. And those 2 muscles are mainly motor muscles, and they contract muscles, okay? The 8th nerve is a sensory nerve sending info to the brain. The 7th and 5th take info from the brain. So the 7th and 5th are efferent, and the 8th nerve is afferent, okay? Always remember those 2 words. You'll hear more of them later, but at any rate. So you've got these 3 different nerves happening. Now, some truckers, you know, the window down, wind blowing against the cheek constantly. I should be here this way. I'm driving the truck, so and the wind's blowing and hitting this ear constantly. It can result in a facial paralysis of that 7th facial cranial nerve. Sometimes it heals spontaneously. Canada had a prime minister about 10 years ago, 15 years ago. He's still living now. His name is Jean Chrétien, a Frenchman from Quebec. He has deafness in one ear and facial paralysis as well. And so he speaks like this, but he said, at least you cannot accuse me from talking from both sides of my mouth, eh? He was cool. I liked him. He had a sense of humor. I have a feeling I've said that on another past Zoom session, but who cares? I repeat myself. Early Alzheimer's. All right, now here we go. So we look at now otosclerosis. Otosclerosis is the last of the middle ear pathologies we will cover. Oto, ear, sclerosis, hardening. Now, sclerosis is actually a bad term for this pathology because it actually is a soft growth of bone around the foot plate of the stapes. It is hereditary. Let's just take a peek at our PowerPoint here so that we can get right into otosclerosis and take a look here. Okay, otosclerosis, eh? All right, here's an audiogram due to otosclerosis. Look at it now. Flat. See, most conductive hearing losses are fairly flat because they are a plug in the ear. Always think of that. Conductive loss is like a plug in the ear. And if you put a plug in your ear, you're blocking all frequencies fairly evenly. Okay? So the right and left ear will have about a 50 decibel, 60, whatever it is, you know, hearing loss. And look at the bone thresholds. They go down at 2000 hertz, and then they get better again. Now this is called Carhart's notch. It's a giveaway. When you do a test and you see something like this, it should make you as a clinician go, ha, I'll bet you've got otosclerosis. This is an earmark, so to speak, of otosclerosis, is Carhart's notch. Remember we talked about otitis media, an improvement in air conduction scores at 2000? Well, this is a decrease in bone conduction scores at 2000. Noted by Raymond Carhart, the father of audiology. Okay, it's one of the landmark studies in our field. What is otosclerosis? Well, let's look at a picture of otosclerosis. Let's see if I've got a, let's see if I can, I'm gonna get out of here so that we can actually look at a picture of it. Ah, here you go. That's the one I wanted to show you. So, look at the middle ear. The soft growth of bone around the foot plate of the stapes. It is hereditary. If mom or dad has it, chances are one of the kids is going to have it. Okay, it's not an infection, doesn't hurt. It's a soft, porous growth of bone around the foot plate of the stapes. So it should be called otoporosis. It's kind of like an osteoporosis that women after menopause get, only in the ear. It's kind of a softening of bone, a porous growth of bone around the foot plate of the stapes. Begins in early adulthood, not usually as children. And it's not an infection, but it causes a middle ear hearing loss, a flat hearing loss with Carhart's notch. And we'll talk a little bit about why and what. Okay, here's the surgery is called a stapedectomy. They've removed the stapes, they've taken away that bone, that soft, porous growth of bone, they've taken that away, and they've taken a titanium wire and connected it to a blob of fat, and they stuck that into the oval window. So that's called a stapedectomy. That's the main surgery of choice. And when we look at it let's look at the procedure of it out of your textbook, Martin. They'll take a proper length of the prosthesis is measured. Then they will drill a hole into the foot plate of the stapes. The hole is then enlarged with a pick or a hand drill. Now, can you imagine how much noise that's going to cause? You'd almost think you're going to cause a noise-induced hearing loss that way, but at any rate, then the crura are weakened and fractured. The incudostapedial joint, okay, the incus and stapedius joint is separated, and the tendon is, the stapedial tendon is separated with or cut, so the person will no longer have an acoustic reflex. The superstructure of the stapes is removed, and then they put onto the neck of the incus, they put this round wire with a plunger into the hole and fill it up with fatty tissue. Stapedectomy. Okay? That's the general thing. So I'll let you follow that for yourselves, but that's the most common treatment. Now, another treatment is wear hearing aids. I know a woman in Canada who worked for Bernafon hearing aids for years. She has otosclerosis in both ears. She said to the physician, heck no, I won't go. I'm not having surgery. She just wears 2 hearing aids. Fine. That's one choice too. The question is here, let's look at why does otosclerosis present with Carhart's notch? How come? Why is it? So here again, something that IHS graduates are not taught. But since you're in a 2-year college program, you are taught. And guess what? At Missouri State in Springfield, their AUD program in audiology also teaches this. So that's why I'm teaching it to you. So that as graduates of OTC, if an audiologist asks you, you'll be able to stand and deliver and tell what it is. In bone conduction thresholds, okay, when you're testing for bone conduction, there are 3 things that give rise to your best bone conduction thresholds, to 0 dB bone, okay? There's 3 things that do it. One's called distortional bone conduction. You're putting the oscillator on the mastoid bone, you're delivering tones through the skull, and you're creating traveling waves in the cochlea. Well, duh. Okay, that's the main contribution. Inertial is another one. Your ossicular chain is attached to skull by ligaments. It's not fused, it's attached by ligaments, isn't it? They call it your ossicular chain. And the ossicles thus vibrate slightly out of phase with the skull. So if I'm delivering tones through the skull, through the mastoid bone, the 3 ossicles are going to wiggle a little bit later. There's an inertia. There's a little bit of a delay or a lack of they're not happening in exact time, okay? Because they're not fused to the skull. They're attached by ligaments to the skull. So because of the fact that they're lagging in action, they're pushing the stapes in and out of the oval window. That's called inertial bone conduction. And the third one's called osteotympanic. When I'm stimulating or vibrating the mastoid bone with the oscillator, a tiny column of air is moving back and forth in my ear canal. And that pushes against the eardrum, helping to push the stapes into the oval window. But when you've got otosclerosis, you've knocked out 2 of those contributions. You've deleted inertial, you've deleted this one, and you've deleted that one. All you've got is distortional. Why? Because now you have fused the bones to the skull. The otosclerosis growing around the foot plate of the stapes fuses the middle ear ossicles to the skull. So you don't have that inertial stuff anymore, and you don't have that little column of air being able to move in and out, pushing against the eardrum, because the whole ossicular chain is fused in place due to that growth of bone around the foot plate of the stapes. Only the distortional contribution, this one here, remains. So bone conduction loss is going to be noticed mostly at the resonance of the middle ear ossicles, hence the dip in bone conduction at 2000 hertz. Carhart's noticed this in 1950. It's one of the classics in audiological literature. The bone conduction thresholds are a result of the mechanical artifact. They do not truly show bone conduction sensitivity. They do not present, or they do not show bone conduction. Here's Carhart's notch again, out of your Martin text. Okay, Martin does weird looking bone thresholds. I don't know why he draws them like that, but at any rate, look at the notch at 2000 hertz. Okay, it's due to the loss of inertial and the loss of osteotympanic contributions to bone conduction. In short, the Carhart's notch is due to 2 things: the way we test bone conduction and the unique pathology that is otosclerosis. You fuse those 2 things together and you'll come up with a mechanical artifact called Carhart's notch. So don't ever think that Carhart's notch represents a sensory neural hearing loss at 2000 hertz. It's a mechanical artifact only of the way we happen to test bone conduction and the unique, peculiar pathology that is otosclerosis. Okay? So never think of Carhart's notch, oh, that's a mixed hearing loss. No, it isn't really. It's an artifact. Okay? That's the only one that's like that, but that's what it is. Otosclerosis, eh? Now let's look here at our notes and see where we've come thus far, right? Yeah, okay. Let's see. Take a look at the old notes. Otosclerosis, we'll read. Fairly common, hereditary in 70% of cases, rare in children, develops in young adults, puberty to age 30. Most common in the white Caucasian race. Most common in women. Noticed especially during pregnancy. Hearing levels are better again after the baby is born. Well, that's because the little baby is stealing calcium from mommy. And when you've lost some calcium, your otosclerosis is going to get worse. After the baby's born, okay, the calcium levels return back to normal again. So actually, it can begin in the bony labyrinth and recognized clinically when it affects the middle ear. But basically, it's a formation of new, spongy growth of bone over the stapes footplate. Osteospongiosis might be actually a better name because sclerosis means hardening. Sometimes the spongy growth covers the crura of the stapes and even the round window. Clients may also show a bluish tint to the whites of their eyes. Weird, I never knew that, but as with other bone, look at the headline, as with other bone dieses. Yeah, nice spelling, Ted. As with other bone dieses. Good. Okay, foot plate becomes partially seized or fixed in the oval window. Results in mostly conductive hearing loss. Clients complain of difficulty hearing while chewing, also complain of tinnitus and hissing sounds. The eardrum looks quite normal, but circle this word, Schwartz's sign. You might see a reddening through the eardrum, not in the eardrum, but through the eardrum, because the promontory of the bone becomes more vascular. Let me put that in English here so I can just show you on a picture. So you can see it, okay? Go here and one up, okay, to here. Sometimes you got the round oval window here and the round window here, okay? Notice where the soft bony growth is. Sometimes this gut gets very vascularized, like little tiny blood vessels all over this. Okay, and so when you're looking through an eardrum with an otoscope, you might see sort of a reddish tint through the eardrum, and that's called Schwartz's sign. Okay, it's another visual thing that physicians use to help diagnose otosclerosis. It's not nearly as common as otitis media. The main biggie of middle ear pathology is otitis media, but Cholesteatoma is a lot less common. Otosclerosis is very genetic, okay, very hereditary. And looky here, put a star by that because that's what I talked about regarding Carhart's notch, okay? There are 3 normal contributions to your bone conduction thresholds: osteotympanic, inertial, and distortional. The normal ear uses all 3 of these modes to give your bone conduction thresholds. The ear with otosclerosis cannot, okay? Inertial is out and osteotympanic is out. You've only got that one here. Only distortional remains, and the resonance of the middle ear ossicles is 2000 hertz. Therefore, Carhart's notch appears mostly at 2000 hertz. It really hurts. Okay, so audiometry and otosclerosis. Here we go. We covered audiometry and otitis media, and we're kind of looking at it here. Low frequency conductive loss, as with most other types of conductive loss, and then as it gets worse, The air-bone gap isn't just in the lows, it now spreads across all frequencies. Okay, begins in the lows, and then the air-bone gap spreads across the frequencies. Carhart's notch is seen in bone conduction. How big is Carhart's notch? About 25 dB, about 20, 25, maybe 30, that would be about the max. Carhart's notch is a mechanical artifact. Okay, put a star by that puppy. Okay, partial fixation of the ossicular chain changes its inertia, makes bone conduction look worse than it is, worse than it really is. Carhart's notch does not truly indicate a sensory neural loss. It is an artifact of the way we test bone conduction. Now look at tympanometry. And let's go back to tympanometry here for a second, and we'll look at what happens with otosclerosis and tympanometry. Tympanogram with very small static compliance. So let's go here. So here's your typical audiogram, Carhart's notch, a flat, moderate degree of hearing loss across the board, Carhart's notch, okay? The tympanogram, a regular type A, will show a normal height. The word static compliance means how tall was your pup tent? Was it a shallow pup tent? Was it a real tall pup tent? They will have otosclerosis will have a type AS tympanogram. The peak will be over normal air pressure because they don't have negative air pressure behind the drum. Their eardrum isn't, their middle ear isn't filled with fluid, so they haven't got a vacuum or a bulge. They don't have that. Okay, there's no infection. Nothing's wrong that way. It's just a tightening and stiffening of the entire middle ear chain. The ossicular chain is made whole, the whole middle ear system, eardrum, malleus, incus, and stapes are all tight, tighter than usual because of that growth of bone around the foot plate of the stapes. Therefore, they will have a type AS tympanogram. A type A, peak over 0, but a real squat pup tent. They don't have much compliance. Look at the top of the tent and go to your left. They haven't got much compliance, even at the best of times, okay? But it's not due to an infection. The peak will be over normal air pressure. They'll have normal air pressure behind the drum, so they'll have greatest compliance when normal air pressure is used outside the drum. The whole middle ear system will be least stiff, but it's still going to be overall more stiff than normal because of the growth of bone around the foot plate of the stapes. Hence a type AS tympanogram. Now you can also get problems going the other way. Here's early otosclerosis, I believe. Yeah, you're getting the beginnings of Carhart's notch, early otosclerosis, advanced otosclerosis. Just thought I'd tell you. Okay, this is, look at this. Here's a tympanogram that's called AD. Okay, that might be from a monomeric eardrum, an eardrum that only doesn't have that middle layer of tissue anymore. It's been so traumatized by perforations and stuff like that it's kind of not very stiff at all. So look at their tympanogram goes off the board. And that's often seen with disarticulated ossicles. Maybe the ossicles are no longer together anymore. And if your malleus and incus aren't touching each other anymore, maybe that joint is broken. Or maybe the incus and the stapes, maybe that joint is broken. So if the middle ear ossicular chain, if one of the joints is broken, once again, you're going to have an overly compliant middle ear system. So the peak is off the board. Okay? 5 types of tympanograms. Type A, type C, type B, type AS, type AD. And you should have a handle or a grip on what kind of pathology will cause each one. Type C, negative middle ear pressure, early otitis media. Type B, advanced fluid-filled otitis media. Type AS, otosclerosis. Type AD, monomeric eardrum or disarticulated ossicles. Just weird stuff. Here's disarticulated ossicles. Look at this. The incus is no longer attached to the stapes. You've got your eardrum. Here's the ear canal. Eardrum, malleus, manubrium of the malleus, incus. Whoops. And look at how the neck of the stapes is no longer attached. Okay, could happen due to an accident, due to a roll of a car. Maybe the guy's had head trauma. Here's a cholesteatoma. Here's a picture of a cholesteatoma. Growth of skin from the outer portion is now growing in to fill up the middle ear space. The growing mass starts typically on the internal surface of the eardrum and extends to fill the middle ear space and mastoid tissue. Mastoid bone. Tissue destruction is common wherever the cholesteatoma is in contact with bony structures. So it can eat away at the bones of the middle ear. Anyway, it's kind of weird. Here's a picture of a cholesteatoma. I didn't think I had the picture in this PowerPoint, but I do. Okay, this is unusual that they show a hearing loss going down like this. Conductive hearing losses usually aren't like that. One thing, conductive hearing losses are usually flat, okay? They're usually quite flat. And this one's showing it sloping. Well, maybe that's because the bone is sloping. So the air-bone gap is going to be the same across all frequencies. So you might have an old man who has presbycusis and bone conduction goes down. If he's got an ear infection, the air-bone gap will be similar across the frequencies. It's like putting a plug in your ear, whether it's excess wax, which doesn't cause much hearing loss at all, or otitis media, or cholesteatoma, or otosclerosis. The air-bone gap is usually fairly flat. Well, otosclerosis is going to be a bit of an exception there because otosclerosis, I mean, here your air-bone gap is smaller. That's Carhart's notch, but you know what I mean. Think of conductive hearing loss as a plug in the ear. Where were we now on here? What I want to do is finish this session. Treatment. So here you go. Type AS tympanogram. Okay. Acoustic reflexes will be absent. Okay. Treatment for otosclerosis. This is just done. You can just read about this. Basically, it's basically a stapedectomy since the late 1950s. Okay, and you can kind of take a look at that, but basically just know for the purposes of this class, the other stuff was more for history. I don't expect that you know this, fenestration, and stapes mobilize. You know what, this one is funny. This one I'll tell you about. It's kind of weird. There's a physician named Rosen. And he said, you guys you're crazy doing all that stapedectomy shit. Like, you're nuts, man. All I do is I put the guy out under local anesthesia. I freeze up his ear. And then I take a little needle and I puncture it through his eardrum. And I physically wiggle the bones. And I pull out the needle again. So the bones were seized. And because I unseized them. And hey, man, the guy's hearing's normal for 3 days. And then seizes up again. That's why the Rosen technique isn't used. Okay? But he thought he really had something. He was thought, yes, I've got it, by Jove, you know? All right, here's how we can finish this section. I will share screen, and it's mainly I'm going to show you a PowerPoint at the very end of our things here. Okay, this is to highlight something. These are the last 4 or 5 slides of your PowerPoint. And it's talking about interoral attenuation for inserts versus circumoral headphones. Now, what does this mean in English? Pretend, look at circumoral headphones first, okay? Circumoral first. All of these people had one ear that was deaf. Right ear deaf maybe, left ear normal. And they had a whole bunch of people, and they said, how much sound can you put into a dead ear before it crosses over to the good ear? On average, around 50 to 60. That's why when you use masking, if the guy's got more than 40 decibel differences between the ears, you decide to do masking. That's why they do that, to be safe, because 40 is less than any of these. Okay? So this is with circumoral headphones. Interoral means between ear quieting. How much sound can I put into a dead ear before it crosses over to the good ear? And there's a gray area because there's a whole bunch of people, but on average it's around 50 to 60. Now let's look at insert headphones. Inserts. How much can you put into a dead ear with insert headphones before it crosses over to the other side? Looky, looky on the left. Way more. Okay? So, interoral attenuation is bigger with insert headphones than it is with circumoral headphones. And people, this may deal with masking in audiometry, but it also says what the greatest conductive hearing loss can possibly be. With the greatest conductive hearing loss depends on the headphone used to test it. If I'm measuring with circumoral headphones, the biggest air-bone gap I will be able to find will be about 60. If I'm using insert headphones, the biggest air-bone gap I'm going to be able to find is going to be about here. Okay, so always know this. Jot it somewhere in your notes. Conductive hearing loss, the biggest air-bone gap that you can measure depends on the headphone used to test it. So it kind of begs the question, you know, like, well, what's the biggest conductive hearing loss you can possibly have? So we'll finish with this here. We've gone for 1 hour, so we're about done. But this is what I want to finish with, and people are welcome to ask me questions next week on all this too, but it's fine. But just look at this. Interoral attenuation with inserts is bigger than with circumoral headphones in blue. That's why I drew this. How much can you put into the dead ear before it crosses over to the other side? This is written by a world-renowned audiologist. Just read it with me. Interoral attenuation determines the maximum conductive hearing loss in audiometry. One lesser-known principle is that an air-bone gap cannot be greater than the interoral attenuation that is determined by the type of the headphone. Thus, a consequence of this principle is that the earphone determines the maximum conductive loss, that is, the air-bone gap that can be recorded on an audiogram. He writes, and we'll just read the slide together. Think of disarticulated ossicles. Think of a person that you've taken the malleus and the incus and you went, okay, so now you've got a big conductive hearing loss because you've severed the bones. Think of that, okay? If you just removed the incus bone, you just took that sucker out. Okay, if the earphones can vibrate the skull so as to generate a bone conduction stimulus of 10 dB in the good ear, so if you can put enough sound to vibrate the good ear by bone conduction, it's likely that it will also generate a bone conduction stimulus of 10 dB in the bad ear. The stimulus level needed to generate this 10 dB stimulus in the bad ear is 10 dB plus the interoral attenuation of the headphone to the bad ear cochlea. The interoral attenuation for the earphone to the test ear cochlea may not exactly be the same as to the good ear cochlea, but we'd expect them to be similar. If the disarticulation generates an air conduction loss that is greater than the interoral attenuation of the headphones will stimulate the bad ear cochlea by bone conduction before the stimulus reaches a level that will overcome the air conduction loss. Thus, the recorded air conduction threshold and air-bone gap are limited by the interoral attenuation of the headphones and may not reflect the air conduction loss. Now, way complicated, weird. I'm not expecting you to know this or memorize. I give it to you for information to read. But look at what it says on the bottom. This is me. Turner wrote that. I didn't write that. I wrote this on the bottom. Kind of makes you wonder what the maximum degree of conductive hearing loss really is. Last time I checked, it was illegal to rip out one's ossicles and fill up the middle ears with cement. Okay? Not allowed to do that. It's kind of, you'll get put in jail for doing that shit. So what I'm trying to say is, we don't know. It depends on the head. All I can say is the biggest air-bone gap you can get with circumoral headphones is about 60. The biggest air-bone gap you can get with insert headphones is about 75. Depends on the frequency. Okay? So what really is it if I removed someone's middle ears and filled up the middle ears with cement and had them walking around? I don't know. Don't know. Anyway, I just leave you with that. That's a point that far too few people think. If you ask an IHS grad, what's the biggest conductive hearing loss you can have? They'll say 60. And all I can say to you is, well, that's with circumoral headphones. With insert headphones, you can measure even a larger conductive hearing loss. Suffice to say, though, most otitis medias don't get beyond 50 or 60. They don't. Most otosclerosis doesn't get beyond 50 or 60. Most conductive hearing losses are mild to moderate in degree. Just FYI, most of them are. But just thought I'd hammer that one little point here. The last thing is this. Someone might ask you a question like this too. Here, I'm going to, what do you call it? See if I can, I'll get out of that. And I'll finish with this because this is kind of cool too. I'm just going to, I know I'm yakking a little bit more than usual, but somebody might ask you this. If the middle ear makes up some 30 to 35 dB, like you've learned in anatomy class, right? The eardrum is way bigger than the foot plate of the stapes. Push your hand against your face, you get some pressure. Push hard against your finger, you get a lot more pressure, okay? The middle ear adds about 30 to 35 dB. Take the Rene tuning fork test, boom, put it on the mastoid, hear it. Hold the tines by the ear, whoa, way louder, right? That's the demonstration of what the middle ear is making up. Then why can a conductive hearing loss often be more than that? That's a question my physician asked me one time, ear, nose, throat doctor with whom I was testing hearing. Said, Ted, if you've learned in school that the middle ear makes up 30 to 35 dB, how come a conductive hearing loss can easily be 60? And the answer is basically something like this slide here. If sound is hitting the oval and round windows at the same time, Houston, you've got a bigger problem. Like this guy's got no ossicles. Okay? Sound is coming in and it's hitting oval and round windows at the same time. Normally, sound is hitting the drum and it's delivered only to the oval window, which in turn bulges the round window. So if the middle ear, yes, it does make up 30 to 35 dB, but if you've got a pathology, see, normally you're pushing in on the stapes and the round window bulges. Okay? But how now, brown cow, if you've got this, if they're hitting the same windows at the same time, then you can have more than a 30 to 35 dB hearing loss. And that can happen with missing ossicles, fluid-filled middle ear, otitis media, okay? Because your whole middle ear space is filled with pus. So you're not getting that exchange of pushing in the stapes while the oval window, while the round window bulges. If you've taken away that interchange, then the 30 to 35 dB that the middle ear makes up can be very much increased to 60 or more. So that little piece was never really taught to me very well. But I'll just stop here, okay? Remember from anatomy, the middle ear makes up 30 to 35 dB. Remember, read that in your middle ear anatomy notes and take a look at that's what it does. That's why you have a middle ear, because the inner ear is filled with fluid, and airborne sound is going to bounce off of fluid, just like if you have your head under a swimming pool and I talk to you from outside the pool, my voice is going to bounce off the water. So what allows airborne sound to activate a fluid-filled cochlea? The middle ear, because force over a big eardrum is converged onto a point called the stapes. Okay, so you'd think, well, if the middle ear makes up 30 to 35 dB, how come a conductive loss can be greater than 35 dB? Well, if that interchange is taken away, whereas the stapes is pushing in and the old round is bulging out, if you have a pathology that's gotten rid of that interchange, yes, you can have more than a 30 to 35 dB conductive loss. And pathologies that will do that are otosclerosis, otitis media, any of them that prevents that exchange, that pushing in of the oval window and simultaneous bulging of the round window. Enough on that. I'm done. How about you all? It's been about an hour and 10 minutes we've gone long. This has been a long Zoom session. Anyway, you guys okay? Ready to kill me? Nah. Okay, next week we're going to start on Unit 2, the inner ear. Okay? Sound good? All right. Adios, amigos. Ciao for now. See you when we look at you. All right.